Hi, I'm Stephen Bettles, Policy Manager at the General Osteopathic Council. We're publishing a series of scenarios related to boundaries with patients, and the first of those, along with our written response, is available on our website. I thought it might help, though, if I talk through some of the key issues of our response to the first case. And this was a male osteopath who's been treating a female patient regularly over a year-long period for complex health issues. This period has coincided with the patient separating from and divorcing her husband, and the osteopath has also undergone a relationship split during this period. The osteopath and patient have discussed this during their treatment sessions, and over the past few weeks the patient has started to bring in homemade cakes for the osteopath at each consultation. They tend to book the final treatment session of the morning and share a coffee and cake afterwards, and now the patient has asked the osteopath round to dinner to see her new flat. So we pose some questions that you could consider in relation to this case. Firstly, what are the boundaries issues in this case? What are the relevant osteopathic practice standards and areas for guidance to support decision making? If a colleague reported this case to you and asked for your guidance, what would you say or do? And if you were presented with a similar scenario yourself, how might you manage this? Well, firstly, there's nothing in this scenario to indicate the relative ages of the osteopath and patient, and nor whether a sexual relationship might possibly develop. There are some potential boundaries issues, however, and we can look to standard D2 of the OPS to consider these in the light of the guidance. So D2 states you must establish and maintain clear professional boundaries with patients and must not abuse your professional standing and the position of trust which you have as an osteopath. The guidance in relation to this standard within the OPS is quite extensive, and it's worth reading the whole section. It starts by saying that the most serious abuse of professional standing is likely to be the failure to establish and maintain appropriate boundaries, whether sexual or otherwise. In this case, we have an emotionally vulnerable patient with a long-standing health issue who's been treated regularly through a particularly stressful period. The recent bringing in of cake at each visit and the booking of the patient in a slot where they can share a coffee and cake afterwards indicates potential inappropriate dependency arising, and it could be argued that this may make the patient even more vulnerable, and even that the osteopath is taking advantage of this and cultivating that relationship. The fact that the osteopath has shared details of his own relationship breakup may have intensified this feeling of connection and dependency and intimacy. The guidance acknowledges that it may sometimes support empathy and trust with the patient to disclose personal information, but there is a spectrum, and it's the osteopath's job to ensure that patients who may be vulnerable are protected. So if a colleague were to ask my advice as to how to manage such a situation, I would have a number of questions. For example, what's the osteopath's view of the relationship? Is it strictly professional and therapeutic, or has it developed into a friendship? Is there any chance that the relationship might become sexual? The guidance to D2 outlines some of the issues that might be sexualized or regarded as so by patients, including sharing inappropriate intimate details, visiting the patient's home without an appointment, making inappropriate sexual remarks to or about a patient, or unnecessary physical contact. So I'd ask, what would be the osteopath's honest reflection on his behaviour in this context? What do they talk about over the coffee and cake, for example? Suppose the osteopath admits there is a burgeoning close relationship here. It may not have become sexual at this stage, but it's heading in that direction potentially, and he wants advice as to what to do. The guidance states it's the osteopath's responsibility not to act on feelings of sexual attraction to or from patients, and in such circumstances suggests seeking advice from a colleague or from the professional body, and says that if you can't remain objective and professional in relation to the patient, and it's not possible to re-establish a professional relationship, then you should refer the patient to another healthcare practitioner. It may be that the osteopath suggests referring the patient elsewhere, in that case, in order to allow the personal relationship to develop. But it's not that simple. The guidance states you must not take advantage of your professional standing to initiate a personal relationship with a patient. There's a power imbalance which may exist even if the patient is no longer in your care. The guidance also explicitly states you must not end a professional relationship with a patient solely to pursue a personal relationship with them. So issues to consider in exercising professional judgment around relationships with patients are the nature of the professional relationship, the length of time it lasted, when it ended, and in this case it's long-standing and ongoing, and whether the former patient was or might continue to be vulnerable, which she was and is in this case. If a personal relationship does develop and at a later stage the patient or former patient felt taken advantage of and reports this, it would be easy for others looking at the facts to see how this happened. And it would likely be difficult for the osteopath to demonstrate that they did establish and maintain clear professional boundaries with the patient and didn't abuse their professional standing and their position of trust. Even assuming there is no potential sexual relationship here, then there are still boundaries issues to consider. Socialising with a patient, in fact combining this with the therapeutic visit as they've been doing, or visiting her new flat for a meal, could develop expectations, thoughts and feelings on both sides unrelated to the therapeutic relationship, putting this at risk. The key question at the heart of all of this is what is in the best interest of the patient, and how can the osteopath establish and maintain clear professional boundaries, ensuring that their clinical judgment is objective and that they provide the care that the patient needs. So my advice to the colleague in these circumstances will be to pay heed to the guidance in the OPS, to take action to recalibrate that therapeutic relationship to a more professional footing. Now, if this isn't possible, to refer the patient to another osteopath or healthcare practitioner, taking account of the guidance which requires this to be done sensitively and in a way which doesn't make it feel to the patient like they've done something wrong. So a full write-up of this is available on our website, as I say, but hopefully this overview has been helpful. Thank you.